I've been an oncology nurse for 20 years. I think there's barriers all over the place. I think there's places that you fall off the cliff. And how do we help you? So then when I went to grad school, I became more vocal than I am anyways, and started walking with patients and kind of seeing there's this gap, you know, and how do we fix this? And really looked at, when I wrote my thesis for my master's, I looked at how do you integrate palliative care into the continuum from diagnosis to end of life, honestly. That changed as I've grown, and I'm still growing up, so just bear with me. That changed as I was enriched by people like you and saying, we're still missing some things here, Michele. So I said, okay, survivorship is this umbrella, and amongst it is shared decision-making, palliative care, advanced care planning, you know, your family, your well-being, all of that. So I've kind of taken that and slowly kind of tried to get most of the people in my practice to drink my Kool-Aid. We have to figure out, how do I work with my community leaders and groups to find resources for my patients? So you quickly got an education. Patients are teaching me all the time. Hello, Michele, didn't you know about? I'm like, no, but thank you, wrote it down. So as a navigator, I got blessed with that, being able to be taught by patients and families saying, in this part of my journey, this is what I needed, Michele. And just continuing to build your resources, and that's what patients have taught me along the way. But community and patients are teaching us so much more because we have to be virtual. I have to work smarter, not harder. You know, I've got to make an impact in the small amount of time that I have in reaching to my partners in the community. So it's survivorship, and truly there's a lot of language, and it took me a long time, and I think this is still a challenge. So for you, as patients, when you look at health professionals saying, why don't you get this? Taking survivorship from diagnosis to end of life takes a lot of resources in order to do this. And so how do we do it to offer the resources that you need? I believe, and I watched it because I took care of my grandma who had 3 malignancies. She went through this journey and when she was 83, and she had multiple lymphoma, and she looked at the family and said, I don't want anything. And the family, my family, said, what do you mean? There's this easy treatment. Why don't you do it? And I was the one that sat next to her and said, you don't have to do it. No, not doing something is a choice. And empowering what is important to you was her survivorship care plan. And that was a lot of diversity to face. So wherever people are in their journey, you got to figure out what you need for your own care plan, your own survivor care plan. And what is that? I tell my patients all the time, I can walk in and tell you what I think you need, and you can tell me I'm full of it. So the true diversion of what I'm doing with patients is asking them to tell me, what are your concerns and how do I help you, empower you? So our conceptual framework is the best thing I ever did, because I kind of struggled with how do we do this? You know, when you ask everybody in the room, everybody's going to have a different definition of survivorship for yourself. And health professionals are the same way. So Ken Miller rewrote Seasons of Survivorship, and he was out of Dana-Farber and kind of part of Lance Armstrong cancer survivorship. And he talks about phases, and as cancer survivors in the room, you know you felt different when you were first diagnosed, and you're overwhelmed, and you didn't know what to do, and you didn't know where to start, and you're trying to understand a disease, a treatment, what am I going to do with my family, my work, how am I going to get there? All these pieces are flying at you, and you don't know where to start. So there's this whole amount of information that you need at acute survivorship. I'm blessed because as a nurse navigator and walked with people through these parts where there's certain things I gave them at their beginning, which is different when you get into treatment and you complete. So I see people kind of shaking their head. You say, when you're completed, you're a little smarter, kind of learned your way, but now people are saying, what is my new normal going to be like, Michele? I'm not even to a new normal. I mean, that's transitional. And then when you get 3, 6 months, year out, your late effects, and you're worried about other things, and you're like, okay, how do I deal with that? That's permanent extended survivorship. So somebody who has reoccurred, and I just dealt with a guy that I sat down with him and I said, I'm here to do your survivorship visit. He goes, I know, I've been avoiding you. I said, well, I'm back in chemo with you. Looks like you're stuck here for a while. What do you think we can talk about today? I did everything I was supposed to do, even went through prophylactic brain radiation, and my cancer still came back. So what are you going to teach me? I said, probably nothing. Probably you're going to teach me more than I'm going to teach you. But I said, in that journey, what were the biggest things that you were worried about? And he sat for a while. We were like, I'm stubborn Bohemian German Irish, and here's the stubborn Norwegian. And it just sat there in silence for at least 10 minutes. And he finally looked at me and he said, when I finished my chemo, I wanted to take my sons hunting. And so we went hunting, and it was at the end of a cycle, 6 cycles of chemotherapy. Guess what? Counts are down, really fatigued. He said, I sat in this cabin 4 hours away from real people and had a fever of 103. But I didn't want to tell my kids because I didn't want to wreck it for them. I said, okay, so what have we learned from that? Because, I've been wanting to do an advanced care plan. I've been wanting to look at my will, but I haven't had the courage to do so. I said, that's where we're going to start. Because it's the power of you not wanting to go back there and wanting to be prepared for your family. So I'm going to give you some tools, and I'm leaving it in your hands. If you need me, you call me. I didn't think he'd call me. I was like, I'm kind of annoying, but I wasn't going to continue to harass him. Exactly 3 days later, he called me and said, I want to sit down with you. I really need help. I said, there you go. Now we started your care plan. So it's different and how we help people. I tell people I'm not a psychologist. I play one on TV. I try to pretend like I'm one to my teenage son, who really blows me off. But I tell him if I can't get to a certain point as a nurse, I'm going to have to send you somewhere else. And you have to choose whether you want that help or not. I can't take you there unless you want to be there. So I can give you all the pieces to build that, but I can't take you there. I can help you, walk with you, be your partner. So we do 3 visits. We do one at diagnosis, one at treatment completion, and one 3-6 months post. Kind of covering that journey. I've had people that call me when things change. And I tell them, I said, I'm always available if things change. If your road is flying along and you're down this and all of a sudden, okay. Progression, side effect issues, those kind of things. Where is there a transition that we need to sit down again? And people have called me and asked to sit down again to help them put their arms around it. So these are kind of the visits and the stuff that we do. And we have a real-time quality of life assessment tool, which argument is whether it's the right one or not. I actually have been it's been kind of cool. It's patients identify their concerns. I got a handout that shows you the printout. They identify what they're worried about. Sexuality, transportation, getting meals, physical stuff. And then they do a quality of life assessment that covers 4 domains of their quality of life: physical, emotional, social, and functional. And with that, we can put a plan together that's their plan and saying, here's what I'm worried about. The most profound thing that happened to me, and I had a guy with stage 4 lung cancer that was in a wheelchair and riddled with bone mets. Horrible pain. And they said, oh, you have a survivorship visit with him today. You really need to do a plan on how to manage his pain. So I walked in, I said, bear with me. Let's do this quality of life assessment. And did it. It took like 7 minutes to do. And when I went in, I had a big, huge, enlightening visit because, yes, he had pain. And yes, he had functional issues. And his quality of life domains were down in that. But he had barely a blip in his emotional well-being. Why? Because he was a caregiver's wife who had dementia. He was the sole caregiver of her. They had sold their house. They had not moved yet. And they were getting ready to look at where they should move for like assisted living type stuff. And he said, I can't get past this. I need to provide for her. Once I provide for her, then I can deal with myself. I said, well, let's try to work on both. So immediate, getting social worker help, getting community stuff, finding out if we've got foundation funds for them. That was a priority. Now, if I wouldn't have done that, what do you think he would have felt like when I left that visit? She didn't listen to me. She didn't hear what my worries were. That's survivorship. That's getting what patients want and what they need and how can I help them. So that's the real-time assessment, and we're doing it with mid-level providers, which is another whole group that we are trying to train down that line about how do you do this counseling and what's helpful for people. And the visit, like I said, goes through. We actually do sit down and go through the treatment plan again. How many of you guys heard the plan? Okay, so I always talk to nurses. Physician comes in, gives you a diagnosis, and guess what? You're going to have this, 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 and this. You're like, then you leave, and you didn't hear any of it, right? And then all of a sudden, oh, time for chemo class. So in our practice, we have chemo class. They have chemo class, and they're like, oh my gosh, I didn't know I had this and this and this and this and this. And then guess what? Tomorrow's chemo. So the anxiety keeps building and building, and the distress keeps building. So we're stopping after the chemo class and sitting down and saying, where are you at? How do I help you? What's missing? How do I take all your loose pieces and pull it together? And that's a blessing of being a crack filler and navigator, kind of walking through with people to say, where are you at and how to help you? And it happens at different time points. So there's a difference, I think, in my mindset between treatment summaries, because you're going to hear a lot about, did you get a treatment summary? Kind of summarizing everything that you've had and making sure that you know that and making sure what your late effects stuff is and making sure that you know what your follow-up plan is. And people feel lost in translation because they complete and they don't know what the plan is. When you're rolling in it, everything's cool, but then you get done and you go, wait, okay, first, nobody's around now. And number two, I don't know what I'm supposed to do. Like, what is my plan? What am I supposed to watch for? So summaries are really important, but a huge part of that is you guys learning how to write your own care plans. What do you need at those time points to look at what do you need for your plan to help you survive? So I've had advanced cancer patients that will say, well, I had the challenge in my practice about why are you doing this with metastatic patients? I'm like, why not? They need it just as much. They need it, there's a lot of things that they need help with, even though they are probably not going to do treatment and or go to hospice and or do palliative treatment. They still need this to build a care plan for them. Patients have said to me, I don't like the name. I don't like survivorship. I'm like, you got up, put your feet on the floor, got dressed, and came to see me today. So you're choosing to survive and live. So let's try to reformulate, recalculate. It's in your journal. Our challenges is we did a pro forma. We had to validate it to our group. We had to say, can we do this financially? Can we offer quality? Do we have the tools to do this? Do we have doing a treatment summary, if anybody in the healthcare people in the room, one treatment summary took me 3 hours to do. Because if you have to manually do it and look at all the records and find where it all came from and get all the details in there, it is very hard to do. So how do we have those resources available? And the primary care physicians, they love that we're sending a care plan to them at every interval of time, saying here's the proposed treatment plan, here's the summary, here's the post follow-up stuff. They're like, this helps a lot, because I give a copy to the patient, copy to the primary care. And then outcomes is we have seen referrals. Our dietitian is like, could you please stop? Because I think every single patient should see a dietitian, and she's phenomenal. So she's like, okay, the other clinic's not using me, so guess what? I'm going to have 2 days a week in your clinic. Yes! So how do we have the resources that we need to provide to our patients? Our social worker says, you know what? I'm not just one for transportation needs or money needs. I can do psychosocial assessments. I can do more detailed stuff. She doesn't have the time to do it. So we are looking to see that we're doing this. Our patients love it. Once I get there, once I sit with them, once they've experienced it, they're like, when's my next visit, Michelle? I'm like, let's get through something and then we'll go to the next point. But if you need help, let's sit down. And that's me.